Good afternoon, everybody. What a great group. So good to see you all. Thank you for joining us today. So, today we have the pleasure of having Dr. Jed Gonzalo with us. And most of you know him, I would hope by now. Did I say Mr. Jed Gonzalo? Dr. Jed Gonzalo, Senior Associate Dean for Medical Education and Professor of Internal Medicine and Health Systems and Implementation Science for Virginia Tech Carilion School of Medicine. Dr. Gonzalo is here and he oversees all of our medical school curriculum. So I think probably most of you have heard the term competency-based medical education. I don't know if most of us know exactly what that means. Dr. Gonzalo is really going to help us to think through that. Also, because he does oversee the medical school curriculum, he's also going to help us to understand more clearly what that means for us here. Dr. Gonzalo strategically has placed lots of points for questions and discussion throughout his presentation today, and he strongly encourages interaction. If he's asking you questions, please feel free to unmute yourself, put your video on if you'd like, and go ahead and engage in some conversation. It's going to make it more exciting for us all, and we'll all learn a little bit more. I don't think I have anything more to say. Go ahead and take it away, Dr. Gonzalo.
Thank you, Sherry. Hi, everybody. It's so good to see several of you on the gallery view here, and let me share my screen. And see the slides okay, everybody? All right, so thanks to Sherry and team for asking me to lead this session on competency-based medical education and assessment. So as Sherry already outlined, I've got several stop points here throughout the talk. So I am less wedded to getting through all the slides. I think having dialogue and discussion in the discussion box would be fantastic. There is an attachment, which Sarah's going to post in the box when she gets a moment to do that. So please feel free to download that. So I'll start with some disclosures and acknowledgements. I have no conflicts of interest to disclose. And it gave me a chance here as I was preparing these slides to acknowledge, like, how did I actually learn about competency-based medical education? So a lot of the learning came from mentors and colleagues of mine over the years, from my former roles. Eric Hombo, who's at the ACGME and several other places, has taught me a whole bunch. Several of the slides you'll see here have been modified from Eric's multiple talks that he was willing to share with me. And of course, the VTC medical education team. We've got a wonderful team here who had been working on competencies and CBME well before I came, but certainly the past year and a half, I would say a common thread in what we're doing is competency-based medical education. So I just want to make some connections with where this sits with the TEACH offerings, and I think there are two direct connections with what's coming up. So Mariah Rudd and I think is leading the Journal Club on Wednesday, January 24th. And it's direct relationship to this session, but evaluating a competency-based blended health professions program, a programmatic approach, which will be a nice node connecting from this session right to this one. And our Vice Dean, Dr. Rebecca Polly, will be leading one of the Health Professions Educator series related to teaching professionalism. So there's a relationship between professionalism and identity formation with what we do in CBME. So I think it's an exciting month of sessions coming up over the next 4 to 6 weeks from what TEACH has planned out. So here's the objectives for us in the next several minutes. We'll define curriculum and competency-based medical education and articulate the differences between both. We'll walk through the 5-stage model of skill acquisition as described by Dreyfus and Dreyfus, which really comes outside of medical education. Then we'll highlight the essential components of CBME and clinical learning environments using the Van Melle framework. This framework is one of my favorite frameworks that exists. I think it's so applicable to all of our work, and seeing all the individuals on the phone on this Zoom call, I think it's applicable to all of our work, no matter which type of role you play in medical education. We'll discuss a little bit of the pyramids of the educational objectives, but mainly Miller's framework for behaviors in the clinical learning environment as it relates to identity. And then threaded throughout will be some examples from VTC SOM, our very work going on in the medical school currently, but also in future. Here's my disclaimer to make me feel better, because CBME is massively big. And I'm just trying to, I feel like I want to deliver for everybody, but we cannot do it all. This is modules that takes hours, courses. What I'm going to do in the next several minutes is hopefully facilitate some discussion and share some key elements of CBME, but there's so many areas that merit a whole bunch of work. For example, coaching or programmatic assessment along the way, or dashboards or precision education. We're not going to be able to do deep dives. So we're really after this systems thinking, the breadth and scope rather than the depth of every particular area. So I'm going to start with the patient case, and just as a primer, this is your first reflection. So you're going to be asked to reflect on this case. Larry's a 79-year-old currently working CPA who experiences a large bowel infarction, undergoes 2 operations, and stays in the intensive care unit with complications of delirium and fever. He's transferred to the internal medicine unit and cared for by hospitals, nurses, therapists, and several consulting services. Unfortunately, several complications ensue, including a delayed diagnosis of hospital-acquired pneumonia, a stage 3 sacral decubitus ulcer, perceived subpar coordination between cardiology, infectious disease, internal medicine, including several handoff errors, both between the services but also between day and night teams. Despite these events, Larry is discharged to a rehab facility where he receives unnecessary salt tablets that result in anasarca. This salt tab order transferred over to the rehab. He undergoes a trip to the emergency department for a diagnostic error. He experiences repeat pneumonia due to aspiration, due to a feeding error that occurred at the bedside and patient positioning. And he misses several physical therapy sessions. Larry is discharged to home with hospice care. He describes his experience at the rehab as being treated like a thing. He dies 8 days following discharge. So what may come across as a little pointed, this is an example that I think resonates. Very few times in healthcare can we see the whole continuum. We're seeing small snippets, but this could be a fairly common example of reality. So here's your reflection. Have you ever experienced on a personal level or as a healthcare professional poor or unsafe care? But most importantly, what is the role of the medical education system, the work of what we do in improving care for patients like Larry? So please feel free to unmute or type it in the box.
Hi, my name is Karen Boucheth, and I'm in the nursing department at the College of Bradford. And I have experienced working in both long-term care and the emergency room, experienced that care transition. But I do feel that we, both in hospital and in the emergency room, first of all, we don't listen to our patients to see what's going on. And the second thing is we don't look at the long-term ramifications of what might happen if they don't have certain resources or the ability to care for themselves at home, including in the rehab. I don't know that rehabs sometimes do what they're supposed to be doing, and we need to follow through with that, if that makes sense.
Yeah, Karen, I fully appreciate that. And yes, it does make sense. This idea of listening to patients, one, understanding their context and what they're bringing to the table, and then looking at the long-term ramifications of what we do. Systems thinking comes to mind. How do we see this holistic picture of what the patients need? So I think, Karen, that's spot on. And I really appreciate you being the first to share. Other thoughts or comments?
Jed, I think all too often that it's the patients who are the only ones who see that full perspective, right? Because they're seeing the patients and or family. They're seeing their family member bounced around from specialty to specialty in the bigger picture, in the various errors throughout. While each specialty isn't privy to that fuller picture. that you described.
Sherry, it's a great point. I mean, as healthcare becomes perceivably more complex and specialized, there's different units, different teams, and it's hard to see and be part of all those different teams. But the patient is the common thread. The patient is the individual with their social network, with their family, experiencing all of these different areas. So it makes it, although good for to have the complexity, it makes it hard to see the holistic picture as the patient is experiencing. Any other comments? I see, David, you're commenting here, not being a clinician, yes, but issues pertaining to handoffs. Physicians may be resistant to standardized training on handoffs, and that might be true. David, do you want to add to that?
I'm not sure I can add much. I've experienced it as regards to patient family members, just observing at the time of handoffs when family members have been in the hospital and noticed that information is either missing, or sometimes it seems like the patient or the family is in the position of having to constantly repeat the same information to different people as they kind of rotate through. And then I was involved a few years ago in an effort to try to standardize patient handoffs with incoming residents. And I forget the model. It's a pretty prominent handoff model that's used a lot in pediatrics, for example, but didn't get too far with that. It just seemed like it ran out of steam in terms of being an urgent issue.
Thank you, David. Any other comments? So I hope what we see in the comments everybody's sharing, that it resonates with all of us about what patients need. And I think that's the end goal of what we're talking about with competency-based medical education. So I do hope that's one of the threads that you see in the next several minutes that we're together talking about this concept. I'm going to start with the competency. Let's define some terms here. Competency, an observable ability of a health professional integrating multiple components such as knowledge, skills, values, and attitudes. I just have a little diagram here on how I kind of keep it in check for myself. KAS, knowledge, attitude, skill. Some place a B on there, knowledge, attitude, skill, behavior. That's what a competency is, but a key point being what I underlined, an observable ability that would be expected for practice of that individual. I did want to start with our North Star in medical education and how professional identity and our mission and vision as a medical school or U.S. medical education writ large ties the competencies. Competencies, one thing we don't want to view it as is a list of observable actions or behaviors that are divorced from our end goal of what we hope for in our graduates in a medical school or graduates of residency programs, etc. So I wanted to start with our identities. These are our VTC professional identities that we have had since the beginning of the medical school that we have recently codified in our strategic planning process. Certainly at the center is the patient-centered physician, the good diagnostician, the person with skills for therapeutic skills to meet the needs of patients. But there's these three synergistic professional identities. The lifelong master adaptive learner, someone who can identify their gaps in knowledge or skill or expertise, use reflective practice and iterate to hone their skills. They're on this lifelong journey. The scientist physician, or perhaps another phrase is inquiry-driven scholar, someone who has the ability to ask good questions, use that data, iterate, and employ that into best practice. And a system citizen. We're all citizens of a healthcare country, nurses, physicians, therapists, and it's all of our responsibilities to be thinking about patient safety and quality improvement, all the social determinants of health that Karen alluded to in our opening comment. These are our identities as at VTC-SOM, and I wanted to juxtapose that to Miller's Pyramid. We had mentioned Miller's Pyramid in the beginning around what an individual or healthcare trainee knows how, shows, and does. And Miller's Pyramid has been around for several decades and really looked at the bottom four tiers of this pyramid. Crewis and Crewis modified this pyramid to place identity at the top. It's the identity of the professional. And it's all related because the knows and shows how and does is related in the same block, the same pyramid. And I just want to connect our own identities. Our identities as a medical school is at that apex of that pyramid, but everything in that same pyramid that is below the identity are the competencies. It's the knowledge, attitude, skills, and behavior, and there's a direct relationship between those skills with the identity. It's our North Star. So I hope what you take away from this slide is that there's a relationship between both. The competencies don't live out in some document collecting dust. It's actually the means by which we achieve our goals and the mission and vision of a medical school. So here's your next prompt. So I'm going to walk through 3 definitions, but I'm going to ask all of you to reflect and share in the comment box. Hopefully you'll unmute and share what you see as the common threads. So I pulled the 3 of the most cited, at least from my perspective, 3 of the most cited definitions of competency-based medical education. So I'll walk through all 3, but I'm going to ask you, what are the common threads that you see in these definitions? And I have them working backwards. I have all the citations at the bottom. One is from 2010, the Frank et al. Article, Ron Harden, who was just here for Medical Education Day, and McGahey et al. From the World Health Organization. So here's definition number 1. An approach to preparing physicians for practice that is fundamentally oriented to graduate outcome abilities and organized around competencies derived from an analysis of societal and patient needs. It de-emphasizes time and promises accountability, flexibility, and learner-centeredness. The second definition is by Ron Harden, an approach to education in which decisions about the curriculum are driven by outcomes that the learner should display at the end of their experience. In outcome-based education, product defines the process, the educational outcomes are clearly specified, and decisions about the content and how it is organized, the strategies, the methods, the assessment procedures are made in the context of those learning outcomes. And then lastly, the oldest one from the WHO, the intended output of competency-based programs in health professionals is at a defined level of proficiency in accord with local conditions to meet local needs. So 3 prominent definitions of competency-based medical education. I'm asking everybody, what are your thoughts? What are the key features or elements that span or cross-cut all of these definitions? Thanks, Hillary. Keep them coming, everybody. Great comments in the box so far. Outcomes, there's a goal at the end. Local learners, thanks, Anita. Local learners, individualized learning. Kim, thanks for that. Outcomes are tied to societal and local needs. It's a key point that I think is pretty prominent that we might not expect if we were to ask what's the definition that comes out of CBME. And David's comment about de-emphasizing fixed time to achieve outcomes. Thanks, Rebecca. Flexibility and adaptability. These are great. Any comments? Please unmute. Time's yours. Please share what your thoughts are.
I have one thought instead of typing it in. I'll just put, I like when it says it de-emphasizes time-based training and promises accountability, flexibility, and learner-centeredness. And I don't think that we always do that.
Thank you, Karen. I think this has been a poignant point of discussion in medical education is time variable education. If we were to shift fully to CBME and our model set up to not be time flexible. So there is this time component that comes into CBME. Other comments?
I am curious what they mean by local. Like, do they mean geographically local or local to the specialty or how they define? Do you have any insight into that?
Yeah, I do. Does anybody else have reflections? Thank you, Sherry. I'm happy to share my thoughts. Anybody else have any thoughts or reflections on the idea of local?
I took that to mean the person who's learning, local to that environment, not necessarily geographical, but I get that it could be both.
I also took it as local conditions. Maybe another word for it would be individualized conditions or meet individualized needs. That's how I looked at it, but I could be wrong.
Yeah, see, I didn't even need to give my perspective. I think both of those comments align with what the end goal is for CBME. If you're building an education program and there's a program called Compadre. It comes out of Oregon and California on the West Coast, but it's really meant to meet the needs of rural patients who are living in rural settings. Your learning goals in that program might be a little bit different than if you're at Mount Sinai or Harvard Medical School in Boston. And it's not to say that the competencies are totally disparate, but the emphasis or prioritization might differ a little bit based upon local needs, which we could, in theory, think about our local needs in Southwest Virginia for Virginia Tech Carilion and Carilion Clinic. So local, I think, could be local at the level of individual with faculty member or local in the context of our neighborhood or our environment. Thanks, Elena. Yes, each community might have specific needs. Elena does work internationally. So what are the needs when the healthcare delivery system looks different in Brazil compared to the US? I think it's another context or lens to look at local. All right. So I'm going to unpack these definitions a little bit, and I hope these are some of the key takeaways that you have when you think about CBME. CBME and the competencies are our outcomes in MedEd. They are what our end goal is, what we're trying to do with every ounce of what we're doing in curriculum and clerkships in the UME to GME transition. There are outcomes. When somebody says, oh, well, show us how medical education improves patient health outcomes, I always pause a little bit when I hear that, because ideally the academic presence would be improving patient health outcomes or population health outcomes, or the quadruple aim, and I think it's all related. But the intermediary step is the learner's skills and abilities in the CBME paradigm that are aligned with improving those patient outcomes. CBME starts with an analysis of both society and patient needs, as Kim highlighted in the box. I think of the work of Charles Bolin and the WHO and the social accountability missions of medical schools. Medical education is not designed to be a static process. It's designed to be dynamic, to meet the needs of communities and people that evolves over time. So if you think about prior to 2000, while all the patient safety events and diagnostic errors as evidence sprang up, we probably focused on patient safety, quality improvement, a lot of the health systems principles less prior to 1995 and 2000. But as we learn more and the society needs are identified more, then CBME aligns with where those needs are for patients. CBME is an approach. It is not a list of competencies that live on a piece of paper. It really defines a lot of work processes holistically, informing all aspects of medical education, from curricular design, learning objectives and assessments, programmatic evaluation. And it requires a high quality learning environment. If we're talking about knowledge, attitudes, and skills that are those outcome abilities of learners or residents, or in our context, physicians in the learning environment, then the clinical learning environment is where it's practiced, learned, and taught. So the quality of that learning environment matters as much as any other aspect, because that's the sociocultural interactions, the organizational structures that allow for the practice, learning, and teaching of those skills. And CBME is tailoring of education to learners' needs. Just like this discussion around local, it requires this faculty-learner interaction for growth. It's very iterative along a continuum. So I hope this slide, this last couple of minutes, these are the salient points you take away from CBME. It's on a list, it's holistic, it's synthetic, and it informs an approach to what we do in medical education writ large. It's not to say that everybody's in full agreement with CBME, so I just want to acknowledge some of the debate perhaps that exists out there. The idea of T-steeping, Brian Hodges wrote a great article 10, 15 years ago about T-steeping and the IDOC model for medical education. But there are some who feel that CBME may be too scripted. They're saying, medical education could be like you place a learner in a learning environment, and if they're in a good learning environment, that with time, they will develop those skills and competencies on their own. You don't need to think proactively about it. but it's like a tea bag. You're placing a tea bag in the hot water, and with time, it steeps. So you place a learner into that environment. If it's a good one, with time, you'll have tea at the end, and you can be less prescriptive. And I think there's been a debate, and there's probably some legitimacy to that, not going too far, not being too analytic in what we do in CBME. But I just want to acknowledge on how some view CBME and going too far with the analytic process. All right. So I'm going to shift here into curriculum. Here's your next stop point too. I just want to make the connection between, we talked about identities into the competencies, and now we're working our way back competencies into curriculum. So please share your thoughts here. What are the core components? When you use the word curriculum, what are the core components that you think of? It's a safe environment, everybody. Whatever you got, just shout it out. Thanks, Elena. Great comments coming through the box here. And there's diversity in these comments too, which is great. There's multiple components of a curriculum, but Hillary's referring to an approach. Sarah might be referring to the experience itself, meeting the student needs, the methods, the assessments, the competence. Leslie's assessments that reflect our desired outcomes that we talked about, meeting societal needs. Kim's talking about developmental skills that develop over time. Yeah, thank you, Kristen. So identifying those most critical information and skills, this honing process and prioritization of what we really want to be learning. And I want to hold on to Kristen's, put a pin in Kristen's comment because it's going to thread through in the next couple slides. Thank you, Kiri. Yep, formal mechanism for teaching. So let's, generally, curriculum is a planned educational experience. So it must have 4 components. This is generally speaking. You must have the goals, and look at all these comments in the box. Several of them are highlighting to expectations or benchmarks for teaching. You need to have some kind of methods, instructional methods, whether it be a rotation in a operating room or an integrated foundational science course for the medical school. The methods need to be there to provide the opportunity for the development of those knowledge or skills. You need materials, and then you need that assessment. And there's a direct linkage between 1 and 4, the goals and the assessment that you have in place. So the curriculum here is used broadly because it's not we might typically think of a course. It's a curriculum. It could be a clerkship. It could be larger experiences. So I'm just showing 3 of the curriculum design frameworks that I have used in the past. We don't need to get into the details of these, but theory-based design, Kolb's learning theory, experience to observation to conceptualization to experimentation, and you repeat that cycle. You can use that to design a curriculum. Understanding by design, Hillary referred to this in the box, this backwards design. Identify those end results, and you work your way back into the learning experiences. And then Kern's curriculum development framework, which comes out of medical education specifically, probably the most cited that I have seen. It's an iterative cycle, but in there, cross-threading all of these is this common thread that there is learning, it has occurred or will occur, and then there is an assessment of that learning. So we're connecting curriculum and these curriculum experiences to those competencies. And this is one of the most referred to figures, if you will, in medical education that compares and contrasts the traditional model at the top, structure and process approach, to the CBME, competency-based medical education approach. They're both at ends of a spectrum. In reality, they kind of play out in this gray zone. But I think for demonstration purposes here on the next slide, I'm just showing the poles of this spectrum just to make some salient points. But in the traditional model is you have a structure and process, and you create the curriculum based upon the learning objectives or the content that you think the learner should know. You build your objectives, you create the assessment, and the learner experiences that curriculum through a unit of time. CBME is a little bit different. It's in many ways, it's reversed. You start with the health needs or the health system needs, patient needs, for example. You build those competencies and the assessments that go with them, and then you build the curriculum based upon those outcomes. So think about the vignette with Larry. All those opening comments that all of you shared, you're essentially highlighting the competencies that are needed for that vignette to have been a more positive one. You start with the health system needs. You identify what are those competencies that are needed, and then you build the curriculum. It's almost in reverse to the structure and process approach. And that's what I'm going to walk through here in this table. This is the heaviest slide I've got. But I think if we grapple a little bit with the structure, process, and the CBME approach, I think you can learn the poles. Now, granted, it plays out a little bit in the middle. But what's the driving force for the curriculum in these two approaches? Content knowledge acquisition is your focus in a structured-based approach, but outcome knowledge application is CBME. The driving force for the process, if a teacher or educator is coming up with the learning objectives, the driving force comes from them. In a CBME approach, it's the learner and teacher in a more co-produced manner because the learner is iteratively acting on or assessing their gaps. The path of learning is hierarchical versus non-hierarchical. It's not to say educators and teachers do not play a role. It's critical, but the learners have some onus of responsibility and accountability in that process. The goal of the educational encounter sometimes is knowledge acquisition in the structure and process approach, but CBME is all about application. Again, a competency is an observable behavior in that clinical workplace, and it's about application. And then the assessment tools, usually they're proxy or removed, while in competency-based, it's authentic, it's in the trenches, it's with the core faculty in the internal medicine clerkship or pediatrics in the clinic. The evaluations are different too in these two approaches. So norm reference versus criterion reference. Norm reference in a structured process approach is, hey, we've got 49 medical students and 7 students are going to get an honors and 15% are going to get a high pass. It's predetermined criteria that is reference across your population of learners versus criterion reference. If all the learners meet those criterion on these milestones and competencies, then we're okay with that. We're okay if all 49 are able to meet those outcomes because that's what we want in practice. All physicians who are able to meet the needs of the patients through those competencies. And the timing of assessment. The emphasis in a structured approach is on summative, while in a CBME approach, it's on a iterative, formative, and low-stakes summative process. Kind of like the analogy of food in a restaurant. The summative approach might be you have this food making process, makes it to the customer in that restaurant, and they taste it. That's summative. It comes at the end of that process. But a formative process is more where the chef and the team is tasting, hey, I need a little bit more salt. Hey, I need a little bit more pepper, a little bit more spice. And you're iterating until you know that you've got a good taste, and then it makes it to the customer. It's a very iterative, proactive process. And the program of completion is always at fixed time in the structured process approach, but CBME may have variable time. Heavy table, but I'm hoping that we're coloring a picture between poles of a traditional structure-based approach with CBME. And CBME really is a paradigm shift that is more balancing between this non-hierarchical application, spreading into assessments, and potentially opening up the space for variable time. Okay. So I want to comment on sense making a little bit in CBME. Are there any comments to this point? Let me just do a stop and a check-in. Anything I can clarify or any reflections that you have?
Jed, I've got a question. This is Joanne. So how, like looking at our new curriculum, I mean, are we going to be flexible enough to really do a variable time program completion?
Yeah, great question, Joanne. I think back to my prior point a couple minutes ago, I think variable time has been a key point in discussion in medical education. Although I'm just speaking personally, this hasn't been, discussed and approved by everybody, but I think the changes that we're making in the curriculum, particularly when it comes to shortening of phase 1, it opens up spaces for an accelerated program to occur. We had the accelerated pathway task force 20% of medical schools have a shortened curriculum. It's typically 20% have a program where you can do it in 3 years. I think we could do variable time in that context, but it is hard given all the structural constraints that exist if you employed CBME to have variable time. A learner graduating 3.5 years, they met all their milestones and competencies. What do they do with the last 6 months or 8 months of their training? Those kind of logistics are really hard. There's pilots out there, particularly in pediatrics, that have piloted time variable, but this is a bigger beast, Joanne.
Jed, I have a question for you, Paul Skolnick here. Great table. The goal of the educational encounter row, you have knowledge acquisition and knowledge application. Talk a little bit more about that, because to apply knowledge, one has to first acquire it. And it strikes me that a lot of our discussions, or at least some of them, center around the best ways to acquire knowledge.
Yeah, Paul, thanks so much for that comment. I'm going to comment on the next slide too, because I think Paul's point is spot on. Like you can't just jump. That's why I said there's two poles and there's some space in between. You can't go apply without knowledge acquisition. I think this isn't my table, by the way. This exists out there in the literature. To flip it, you have to have that knowledge base to apply. The structure approach might, if it just stops at knowledge acquisition and it's assumed that it could then be applied, is where it breaks down. And I think that's where CBME comes into the picture. It says, hey, we can't just stop at knowledge acquisition. We got to translate that into the clinical space. Does that help, Paul, or no?
Yes, thank you.
All right, so I know some of the terms are challenging. So I got 2 slides here on sense making, and I love history, so I am going to try to provide some context on history. I'm just going to hit some of the salient mileposts just to nestle where we are for CBME. And I take it back to the Flexner report that was funded by the Carnegie Foundation back in 1913. This is to Paul's point that he just made. This codified medical education in many ways exists to this day. The 2+2 model, learn in a classroom, take it in the clinical space and apply. It was this transition from practice-based knowledge to knowledge-based practice. That's what the 2+2 model was seeking to do, the early forerunners of CBME. In the early 60s, the Office of Education developed National Center for Education grants. This is not in medical education. This is in higher education, really focused on outcomes-based education. Hey, we need to transition away from this structure process approach that's fixed in time and think about what are those outcomes. And then in 1978, the McGahey work, the WHO work said we need to promote CBME in medical education. So you see, we went 60, 70 years, and not without CBME, but it wasn't a CBME approach until the 70s and 80s. But it still wasn't adopted in U.S. medical education. And there were a number of events between the 80s all the way up to 2001, and I'm just going to highlight 3 of them. The Libby Zion case, 18-year-old woman admitted to a New York University hospital, dies within 12 hours of admission, presumably from a drug-to-drug interaction, identified a whole bunch of systems failures and medical education gaps that has informed a lot of what we do in medical education today. The Harvard Medical Practice Study, a study that's looking at adverse events and medical errors in hospitalized patients, which was about 4% of hospitalized patients experienced an adverse event or medical error. And the IOM reports, which articulated a lot of the patient safety gaps, the crossing the quality chasm, for example, the diagnostic errors. This laid the platform for competency-based medical education in U.S. med ed, which allowed for the ACGME to approve the core competencies at the GME level and then at the medical specialties level. And they were formally adopted in 2001. So we're about 23 years into this CBME paradigm, and we have a long way to go. I mean, we're still sprinting on it, even though it's 2 decades in. Carnegie Foundation, again, put out a report in 2010 and said, hey, we need to keep moving with assessments in the clinical space. 2013, the work by Englander and Caraccio identified the UME, GME, CME competencies. We had a framework. although the competency started in GME, UME has really struggled with a common framework. Today, we do not have a common framework for competencies that exist across medical schools. This article helped. The ACGME Next Accreditation System said, hey, we're in this process for 10 or 13 years. We got to add some granularity to the competencies, so the milestones were adopted. The EPAs, the entrustable professional activities, were adopted not adopted, they were recommended in the UME lens, and several medical schools incorporated those in, as did we as a medical school. And then the harmonized milestones at the GME level help provide granularity to the competencies. So the past 20 years has been a honing of the CBME journey that we're in. So all the work we're doing locally right now comes in the context of this historical past. When I have struggled with the language in competency-based med ed, I think of this figure. That's why I'm sharing it. This one that integrates EPAs, DOC as domain of competence, C as competencies, and M's are milestones. And they're all related. They're all part of this CBME paradigm. So the entrustable professional activities are units of professional practice that may be entrusted to a learner to execute in an unsupervised manner once they have demonstrated competence. So in many ways, the EPAs requires the building blocks that exist to the right of the EPA in this figure. Let me see if I can annotate. So here's the EPA, but all of these are building blocks that build up to the EPA itself. So this is all a workplace descriptor. So EPAs, if you think about EPAs, it's everything that's happening in that workplace. The competencies are mainly person descriptors. They could happen in the workplace. They could happen in an OSCE lab. They could happen in other venues, but it's mainly about the individual. And the milestones are the building blocks for the competency. So you become more granular as you move right in the figure. The EPA is this overarching unit of work that we can observe in the clinical space. What can I clarify here? What's confusing here, or share any thoughts that you have in this spot?
Jed, I think one thing that comes to my mind when I look at this slide is that it would be easy to look at this and feel like there is universal agreement on each of these categories, but in fact, there isn't, right? So what one group says is a competency in, say, for example, systems-based practice. Some other group or some other specialty may take that same thing and say, no, this is a competency in a different category. And the same thing with EPA. So I'm glad you said we're only 23 years and we got a lot of work to do, because a lot of the work we need to do is figuring out how to talk about this so that we're all speaking the same language and having the same things in mind when we use these terms, because we're far from that in my judgment. Am I right about that?
Yeah, David, I think you're spot on. I think you bring up a couple points, but one of them is the continuum. I'm seeing Karen here, so I'm not excluding the nurses. I'm just thinking in the context of the glasses of a physician. The UME to GME to CME transition that exists. We are all working on different models of competencies or CBME in some variation. There is commonalities, but it's hard to think about the transition when you and me, we're trying to prepare for the transition to residency. So it's hard to facilitate along that continuum. I do think we're further along than we were 5 or 10 years ago on what lives in systems-based practice or practice-based learning and improvement. I think there's increasing clarity about what goes into those domains of competence. But thank you, David. Any other comments? All right. So this is the Van Melle framework. This is one of my favorite frameworks. If anybody's interested about your local work, I would just read this article. I'm going to walk through the 5 tenets, but I'm going to apply it to a VTC SOM example for each of them. But I'm also going to ask you to reflect, are there any examples that you have using this framework? So one, there needs to be an outcome-based competency framework that exists. These are the desired outcomes of training identified, again, based on societal needs, and the outcomes are paramount for functioning in practice. It's that knowledge-based application. So a VTC example could be the work of the scientist, physician, or our research domain that we have across the years. There's 159 MD schools. There's 41 DO schools that exist in the US. What is our brand? What is our differentiator? One of the key areas is the scientist, physician, or inquiry-driven scholar. We believe that in this outcome-based competency framework, those skills, those deep skills of being the scientist, physician, will be part of the workforce, leading clinics, leading initiatives in that clinical space in health systems so much that it's part of our educational framework that meets the needs of society. Number two, to have a full CBME program, you need to have progressive sequencing of competencies. There must be building blocks that work along that continuum from time point A to B to C. And this is vertical integration. How do you integrate across from the learner's experience from phase 1, for example, to phase 2 and phase 3? The example I have for this is clinical science, OSCEs, and standardized patients. So we do amazing work. Let's just take the example of history taking or history construction. We do great work in phase 1, and the learners are learning the core components and they're practicing and they're demonstrating and we're assessing. And then when they transition into phase 2, they should be picking up where they left off from phase 1. We shouldn't be repeating that cycle through the MS3 orientation, through the clerkships, and into phase 3. That it should be developmental and it should progressively sequence along the learner's growth. This is easier said than done. Medical schools really struggle at vertical integration between those phases, and we're just in the throes right now of thinking developmentally along the sequencing of the competencies. The learning experience should be tailored to competencies in CBME. So the experience itself should provide the venue or the milieu for the competencies to be developed. And the example I have for this is the work by Dr. A. Luk Tong in surgery and Dr. Natalie Karp in OB-GYN, as also the HSSIP champion lead. The work that they're developing now is an elective. Hey, we have gaps in health system leadership, patient safety, QI. So they're building an elective that will be piloted for the first cycle to help learners develop those skills in real-world examples of surgery, with the idea that it's going to be developed further into the capstone. But the experience itself of the elective or capstone is a vehicle for the competencies that we want. These competencies are clearly listed in our educational program objectives. Rather than, the alternative would be, hey, well, we have this idea for an elective. Let's build the elective and then think about the competencies afterwards. We're trying to back engineer with where the needs are with competencies first, and then the learning experiences follow that. The teaching in those experiences then should be tailored to the competencies. And this is where it comes down to learners and teachers or educators co-producing their learning. It's the feedback, it's the iterative growth. Imagine if you're a hospitalist on internal medicine and you're providing feedback and engaging in that education process with the learner. The guide should be the competencies. It shouldn't only be about the knowledge piece of SIADH or elevated TSH. Yes, it should be that, and it's also the competencies of growth through teaming and communication and professionalism and systems-based practice. So the integrated foundational science course is a great example. This is one of the most active areas of our curriculum right now as we try to build a horizontally integrated foundational science course. Take, for example, anatomy and clinical science. How do they come together integrated in the minds of the learner to think about functional anatomy and the clinical science skills on a knee exam? The teaching is tailored to what the competency is for the individual in practice. In our context, a student on a clerkship or a student entering as an intern. And number 5 is programmatic assessment. This is more of a synthetic view. A lot of it comes to Dr. Mutchison's shop, but multiple data collection points. It's an emphasis on workplace-based assessment, progression based on entrustment. Many medical schools have transitioned to coaching programs. We're hoping to pilot a coaching program coming up in the new MS1 class, the building of dashboards that ties into precision education. Precision education is using the data to inform individual learner development and growth along their continuum from entry to graduation. Very few med schools have a clear understanding across the spectrum of these milestone and competency development about where the learner is and how do you coach. Coaching relies upon that data that is iterative. So this is very aspirational for us and many medical schools. Many medical schools are already there. Vanderbilt, Oregon, NYU, they've got robust dashboards that really drive their precision education. This is the Van Melle framework. It gives you the systems thinking view of a CBME program across these 5 domains. So I'm going to ask you to reflect here, or what examples do you have? Everybody's good with this concept, these concepts? Okay. All right, I'll close with learning curves in CBME very briefly. The EPO document we sent around, that's there for your reference that you can look at. But they're the EPOs that we built for the School of Medicine. This is my daughter's first basketball game this weekend. This is Caroline right here. She is not getting the concept. She's 5. She's not yet getting the concept that she needs to look at the ball, and we're trying to put the basketball in the hoop. So I guess I have failed as a dad. And this is our great coach, one of our great coaches, showing her, hey, Caroline, you got to look at the ball. And I may or may not have been daydreaming about CBME when I was watching her on the court. But then I was reminded this is a learning curve for her. This is her first basketball game. In many ways, it ties directly to CBME and the Dreyfus model that we have been alluding to here in this talk the whole time. But here it is, the Dreyfus model, these layers of developmental growth from on the X is time spent in effortful training or practice, and the Y is the performance of the individual, those skills and competencies. So Dreyfus outside of medical education built these novice, advanced, competent, proficient, expert. And with time and deliberate practice, you make your way along that journey to become more deliberate practice and expert. In many ways, when you, in the physician lens, you put medical school is generally at the more novice or advanced phase. Graduate medical education is further along, and then you make your way up along that continuum. That's why the continuum is so important. So what's required, though, for that learning curve? There's a couple key concepts here that I think is really exciting to think about when we think about medical students in particular. Certainly legitimate participatory roles. You can do several talks on this concept alone. It's the idea that to actually develop your skills, you have to be able to demonstrate or practice those skills. You need legitimate participatory roles in a community of practice. If we're sending learners out to observe, then that implies that what they're doing is they're just observing the knowledge piece, but they have to be given opportunities to practice. If we're teaching them the core areas of history construction, for example, then they have to go out and be able to practice through significant roles in that process. Easier said than done. They need reflective practice. They need to be able to reflect on what those assessments are and their milestones, get feedback through that coaching process, and then act on it. Do this deliberative practice is the work of Erickson et al. To say, if you don't practice iteratively, then you're not going to be able to develop that skill. And that comes through coaching, which is it's not a fad in med ed, and it's really one of the foundational bedrocks of CBME. And all of this requires a growth mindset and systems thinking to actually make that happen. You have to have a growth mindset to actually engage in this growth development along these curves. So this is just an example, and I'm going to close with this one. So this is the Dreyfus model across these spectrums. I'm just taking one example of providing an oral case presentation of a clinical encounter. This is one of the entrustable professional activities. So these are hypothetical. The novice might be, does the novice understand the core components of a case presentation? So a first-year medical student who's 1 month in, they might many of them have been scribes, so they understand that. But for everybody, novice level is understanding the core components. The advanced beginner can deliver a presentation that may not be concise, or maybe it wanders. When I'm working with a third-year clerkship student and it's their first rotation, many times this is the case. They know the components of it, but it's not honed to the degree that we want, which is okay. The competent student can deliver a presentation that's organized around a chief concern. The proficient student can integrate pertinent positives and negatives to support a hypothesis. And then the expert can do it at the full grown, filters, synthesizes, prioritizes information in a concise, well-organized presentation. This is an example of what we're trying to do when we think about precision education, our dashboards or our assessments in CBME. We have to be able to create those milestones, which we're doing. Where do we assess each one of these milestones? There's a lot of back work that needs to happen. Well, where do we ensure that we can assess that they're at the novice level, that they can deliver a presentation that may not be concise or wanders? We have to intentionally design those assessments into our process. So I'm going to end with this. I had some things about the competency frameworks, but the EPOs is what we're building. That's what the attachment is. You can keep that as your reference. This has been approved by our core curriculum committees. And it's really our journey, our ongoing journey towards CBME. So I'm hoping we're able to accomplish some of these learning objectives. We define curriculum and competency-based med-ed. I'm hoping you understand the Dreyfus model, at least the core principles. The Van Melle framework you can refer to as you're thinking about the systems thinking view holistically of a program. Miller's pyramid and the relationship to identities, professional identities. And then some of the work that we're doing in the School of Medicine that's really on a journey for CBME. So thank you to Sherry. Thanks for the team for having me, and happy to talk, comments, questions.
Thank you so much, Jed. This was super helpful. Big concepts, big concepts. Lots of wonderful models to help us to connect these big concepts to reality. What types of questions or comments do folks have, either in general or practically speaking, about implementation?
I have just a clarification, Jed. I'm still struggling, this is Joanne, with the difference between a competency and an EPO.
Let me share again. Come back to this one.
I know you said person and work centered, but I didn't quite understand that.
Yep. So for everybody who may not know, every medical school from LCME, our accrediting body, is required to have a compiled list of educational program objectives. These are essentially the outcomes of the medical school. So our EPO document, which I had in the last segment, is really a compilation from 3 or 4 different frameworks. So our EPO document blends competencies and EPAs into one unified framework of EPOs. So it's a little bit of a mishmash of competencies and EPAs, but there's a reason for it. It's because some of the EPAs, that the goals that we would want for the long term, we don't think that learners can do by the end of 4 years of medical school, that it actually happens in the R2 or R3 of residency, which means our EPOs are components of that, which are the competencies. But there's things that we believe that they can do by the end of medical school that might be EPAs.
Okay, so that was, yeah, I think I might have said EPO when I meant EPA. The difference in a competency and an EPA was, but that last thing actually was helpful too.
Yeah, sorry, Joanna, I didn't. So I'm just going to show everybody I think I saved it here. Here's the EPAs. These are the entrustable professional activities that have been codified in 2014 on that history timeline by the AAMC. So you can see these are, like, just take one. I don't know, collaborate as a team member of an interprofessional care team, EPA 9, which we're required to do by accreditation for interprofessional collaboration. There's a lot that goes into EPA 9. If we were to unpack EPA 9, there would be several competencies and milestones that would go with the EPA. that we're doing already in the curriculum. We don't just say, hey, we're going to do EPA 9, assess it one time and done. We're doing the building blocks, and ideally by the end of medical school, maybe they're able to do EPA 9.
Okay, thanks. That's helpful.
Yeah, David has a question. I sometimes hear clinical faculty bemoan the fact that medical students are not allowed to practice their skills as much as in the past for a variety of reasons. Are you concerned about this? And we recognize that it is 1 o'clock. So if anybody has to leave, please feel free to leave. Whoever can stay for a couple more minutes for answer to this and other questions. Thank you.
Yep. Thanks, everybody. David, it's a really great question. I mean, I'll give you my own opinion. And we've written a couple of papers about this. And the textbook that we wrote that's entitled Value Added Medical Education, in many ways, was I don't want to call it the burning platform, but the rationale for the book itself was based upon the fact that learners are becoming more marginalized in clinical settings for a number of regulatory, cultural, hidden curricular reasons, and they're not able to perform legitimate peripheral participatory roles. They're not able to contribute in some way. We wouldn't expect a clerkship student to decide on the dose of the diuretic and prescribe it unsupervised. That's not reasonable. But it is reasonable for a learner to be pre-rounding on patients, constructing a history, presenting, placing orders that can then be co-signed. These are active participatory roles that I think in some ways has gone us far away from the era of World War II, and we were relying upon acting interns to actually run the hospital, to actually do the work and contribute in the gap of a workforce need from a physician lens. And some of it's legit. Some of it probably is good. Maybe we had students doing too much, but there is a balance somewhere in the middle.
Jed, Paul Skolnick again. A great talk. Thanks for putting that all together. It strikes me that we've been churning out physicians for, as you pointed out, decades. And they seem mostly to get to a good place. This is a new methodology. So I have two questions. Well, one more comment. A lot of what's happening now strikes me as writing down in detail expectations. There were expectations all along, but they were never made explicit or as explicit as they are now. So my question is there a way to compare outcomes, if you will, in terms of quality of physicians? Whatever parameters you want to decide or prove past, testing, board examinations, it would take a long time, and I can't think of a design to do that comparison. Is that, because what's just like with the Flexner report, compared to what? Is CBME better compared to what? It's hard for me to envision how we can know that.
Yeah, thanks, Paul. I mean, as usual, Paul's got some of the deep conceptual questions, which are really good. Your question reminded me of the work by Ken Lubmer. If anybody's ever interested in the history of med-ed, I mean, these books that Ken has written, they're fascinating. Let Me Heal, Time to Heal. The Let Me Heal book is around the genesis and iteration of graduate medical education in the U.S. Goes all the way back to the 1880s and the launch at Hopkins and other schools, and progresses all the way through, I think, to the turn of the century. One of the premises in that book is when the resident physicians used to live in the hospital, that's what their home was. Their hours were not counted. They were there. They were fully immersed. So take for a surgical residence, for example, I think one of the example he uses is the number of appendectomies that a surgery resident would have participated in or led. Could have been X number, insert number, but it really high. And then you fast forward to today with duty hour restrictions, the teaming, changes in regulatory of who's actually doing the surgeries. There is data to show that the number that a surgery resident would do has come down. So that delta then creates the question, how do we know that instead of 100 appendectomies, that the 20 they did allowed them to develop the skills to go out and perform the appendectomy without the supervision of a surgeon. And I think that was one of the spawning of CBME, to say times have changed, contextual factors have changed. So how do we ensure that the outcome is learning? It's not a process of you can T-steep in the old model of the 20s, 30s, and 40s, because we didn't tabulate outcomes. We didn't look long-term at the outcomes for some of it, but it was also because there was many more hours doing appendectomies in that example, maybe not so much now. So I know that clearly doesn't answer the complexity of your question, Paul. I think I'm trying to highlight the contextual factors that exist on why CBME is so critically important, which I know you'd agree with, as compared to the time-based model in today's context.
Thank you, Jack. Thank you all for being here. Thank you, Dr. Gonzalo, for your fabulous presentation. As you all know, he is right in our medical education building and throughout the hospital when he's caring for patients. So please don't hesitate to email him, stop by his office, see him. And he's happy he loves talking about this kind of stuff. So happy to answer any questions further. If there are no more questions or comments, I will bid you all adieu and have a wonderful day and stay nice and warm. See you all.